Hello, and welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center. And our program, Digital Slide Review and Sign Out, is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. So we're going to deal with a quite interesting case that came across my desk this past week. The patient is an elderly woman who's undergoing routine screening for colorectal cancer. She's 66 years old. She has a history of a variety of chronic medical diseases, diabetes, hypertension, little mild renal failure, and so forth. She's just getting good care and management by her physician. Just to maybe start this off, I thought maybe we'd just briefly review what the current screening guidelines are and some of the methods that are available out there to do this. First of all, because we're encountering a larger number of patients in earlier ages who have colorectal carcinoma, the age at which screening is recommended to begin has been dropped to 45 years of age from 50. And this should continue for the next 30 years till about age 75 on a fairly regular basis, depending on the methodology chosen every year or every 3 years, every 10 years, and so forth. Over age 75, of course, there still is a persistent risk, but in general, it's not believed that you're going to detect new polyps, new risk factors at that stage. And so if someone has been completely clear, you may discontinue or significantly taper back screening at that stage. On the other hand, if there's a family history, it's certainly prudent to begin screening at an earlier age. And this is based on the age at which the youngest relative was found to have cancer. Given the lag time in developing clinically evident lesions and significant life-threatening lesions, it's thought that about 10 years prior to the youngest age of clinical manifestation is a reasonably safe time frame to begin. Now, what methods? Well, in our country, generally, I think most people use colonoscopy with an entire examination of the entire colon at 10-year intervals. That, of course, then is increased in frequency if significant findings are identified. There also, however, are immunochemical tests, fecal immunochemical tests or fecal occult blood tests, which can be used and have not untoward sensitivity. But certainly in terms of developing the earliest lesions, these are not quite as efficient as colonoscopy. But certainly the immunochemical test has very good sensitivity as well. CT or other imaging can be used in some circumstances, but again is not quite as optimal as colonoscopy. An interesting question is what will be the ultimate fallout role of molecular blood tests using circulating DNA or other gene product markers for colorectal carcinoma. Some of these have shown great promise. And recently, a new one was licensed by the FDA. So that bears some watching to see where those will fit into the overall schema of screening the population. Because certainly we've had some difficulty getting the entire population into screening with colonoscopy. Just in terms of incidence of polyps, it's very difficult, of course, to assign this for a worldwide population. But it's felt that roughly 400 per 100,000 people will develop adenomas at some phase during their lives. And then of those who have polyps discovered, about 2/3 of those are dysplasias or adenomas, whereas serrated polyps, which includes the hyperplastic polyps, but also the serrated adenomas, traditional serrated adenomas, and so forth, account for the majority of the other 1/3. Hamartomatous polyps and inflammatory polyps are a very significant minority of the cases. So let me shift now and share with you the particulars of the case and see what the biopsies on this particular patient looked like. So as I mentioned, she underwent um, screening colonoscopy and had biopsies taken from several different sites. The first was somewhat in the proximal colon. As you can see here, there are several fragments. And at low magnification, these look really quite unremarkable as we look through these. And I was ready almost to call this normal tissue, but then something a little bit abnormal caught my eye, and I just sort of glanced at this and said, I wonder what that is. So is a cluster of cells, fairly abundant cytoplasm, round nuclei, uniform. I wondered, is this a neuroendocrine tumor or something like that? And we're just getting the tip of it. I wasn't quite sure what this was going to be. Then I saw, oh, over here, we have a little bit more of this sort of thing. A few of these types of cells clustering around the bases of several of the crypts. They have quite prominent nucleoli, some of these cells. The nuclei is a little bit eccentric, and I thought they look a little bit like ganglion cells, which normally you don't encounter in the colonic mucosa lamina propria. Usually ganglion cells are isolated in the submucosa and in the muscularis itself. So we went on then to the next sample, and we'll sort of zoom out here so you can see this a little bit. And I go, okay, here's a routine polyp here. You see a nice tubular adenoma. So yes, she's making adenomas. This fragment looks pretty unremarkable. Little lymphoid aggregate here, and maybe a little bit of something right here. Not quite sure if that's going to pan out to be anything, but given what we saw with the earlier biopsy, my suspicion is raised. Then we come over to the third fragment, and this fragment looks decidedly different. The lamina propria is pinker. It has less cellularity. And as you can see, there's a little bit of maybe vague nodularity to some of this tissue. I'm sure many of you have already begun to recognize this looks like a mucosal Schwann cell hamartoma. And in fact, we do have sort of a fibrillar spindle cell proliferation. We have some plasma cells in here. And not quite sure what that is, but these look like otherwise fairly normal appearing plasma cells up here in the lamina propria. We can look at a few other areas in this tissue fragment. There you see a little bit of nice whirling, a rounded, almost corpuscle-like architecture here. But none of those large ganglion cells that we saw in the earlier biopsies. And then we'll come here to the last biopsy. Here we should be able to see we have a much larger fragment of tissue. And at low magnification, This has a decided pattern that looks very much like an inflammatory polyp. We have sort of loss of some of the surface epithelium. We have these hyperplastic, somewhat altered architectural glands. And I was thinking, okay, well, maybe she's got a little rectal prolapse or something like that, and she's getting an inflammatory polyp. And I was almost ready to go ahead and sign the case out with those abnormalities. But then I thought back to those ganglion cells that we had seen earlier. And so I went to higher magnification here. And sure enough, look and see what we found. Scattered uh, in large cells with sort of eccentric nuclei, prominent nucleoli, a little bit of missile-like substances, bluish material at the edge of the chromatin. And so indeed, we have a ganglioneuroma of the large bowel. And in fact, that then would begin to explain the presence of both the mucosal Schwann cell hamartoma as well as the earlier little nodules of ganglion-like cells in the earlier tissues. And here you can see more of this. Here's, again, this sort of Schwann cell type of tissue, but coupled with ganglion cells here in the lamina propria, streaming, sort of spindle-shaped cells. These would be strongly S100, of course, positive. And then the backdrop looking very much like an inflammatory polyp. So what does that put us with? Well, let's come back to our other slides here and talk about the features of ganglioneuroma. We've talked about polyps here. These are decidedly rare lesions, not a common cause of a colon polyps. And as I've mentioned, they're very similar, almost histologically identical, with the exception of the ganglion cells, to mucosal Schwann cell hamartoma, a lesion that we see, recognize, feel great and proud of ourselves, but makes absolutely no difference to the patient. And I think you may recall, I've said previously that if you miss that diagnosis, it's not a big deal. But in this case, this is something that you probably don't want to miss. Because especially in a situation like our patient, where you have multiple polyps, the possibility that this patient has Cowden syndrome or some other P10 hamartoma syndrome is of much greater potential. And importantly, as these have been described, these are often associated with other histologic types of polyps. We've seen how they can mimic inflammatory polyps, how they can coexist with tubular adenomas and so forth. And so this presentation is fairly characteristic of ganglioneuromas of the colon. The differential diagnosis, of course, we've indicated also includes inflammatory polyp, ganglioneuromatosis, which is a much more disseminated and widespread sort of plaque-like proliferation of these lesions. And then other neurofibromatous lesions, perineurioma, and obviously sometimes this could be mistaken for normal colon. So our final diagnosis in this case was ganglioneuroma of the colon, multiple sites associated with tubular adenoma, and suggesting that the patient be considered or evaluated for possible P10 deficiency syndrome or mutational hamartomatous syndromes such as Cowden syndrome. Well, I hope that you enjoyed that and that you'll let me know any questions or comments you have. I certainly encourage you to subscribe. That's a great way to get news of new releases from our channel. And in the interim, I wish you well and look forward to being together with you again. Thanks so much for joining me.